All right, well, hello everyone again, and for those of you who made it through a long day today, we went through a lot of cases, calcium tortuosity, hemodynamic support, CTOs, and now a great fun part, which is an amalgam of many different cases. We will have Dr. Gulati moderating the session with me, and then we'll have a great panel, Dr. Amit Amin, non-catch angioma, Shunk, Cihan, Cevik, Vlad Javik, and Rhian Davies. And we will start with the first case with Dr. Konstantinos Voudris. He's going to talk about PCI in a TAVR patient, something that is very simple as he's going to show to us and nothing to worry about. And then we'll ask all the speakers to please look towards the audience. It's not good to turn your back on the audience, and we'll be hearing on the back here. Thank you.
Perfect. Thank you. Thank you, everyone, and thank Dr. Brilakis for the invitation to present today. It's a little bit different than what you were seeing in the prior session, and it's a case of a 75-year-old male. He presents for evaluation for aortic valve stenosis. He has heart failure with preserved ejection fraction, severe COPD, mild coronary artery disease, clearly symptomatic, NYHA class 3. All the echo parameters fit severe, classic AS, high velocities, normal EF, high gradients, with no other severe valvular abnormality. And those of you who are familiar with the TAVR world a little bit, there's always a workup that involves cardiac CTA, and that's where we get a lot of the information for what we do. So you can see annular measurements, you can see calcification, and predominantly you can see that the non-coronary cusp leaflet is the one that's primarily calcified. There's a little bit calcium on the left, but not really significant. Coronary heights are good. It's one of the parameters that we look for, trying to make sure that when we put a valve in, the leaflets from the native valve do not obstruct actually your native coronary arteries and create bigger troubles. So good access, everything pretty much is set up for a kind of straightforward case. And that's what we hoped for also going in for this case. So we got our access, we have our pacemaker in, we are across the aortic valve, everything is looking good. We're decided to go with a self-expandable valve for this case. You can clearly see we're trying to make sure that we apply everything in order to get commissural alignment. So you see those arrows. There's a little hat marker on the side of the valve for those that are not familiar that we actually look at it at the descending as well as right on top of the aortic valve, make sure that it's sitting on the outer curve of the valve, and that actually allows us to ensure that to a good extent we'll get commissural alignment. And I'll touch a little bit more on commissural alignment in a few minutes and why is that important to everything else we do and everything else that anybody else that would want to get access to coronaries will have to do. So we proceed with our valve. We always deploy in CASP overlap. We take our injections at 80% and we switch to our 3-cusp view. We're pretty happy with the depth. We had to recapture once just to be sure that we're sitting at the nice position. There is markers on the valve, so it kind of makes our life easier, making sure that the depth is adequate. And we deploy our valve, we release our valve. We're pretty happy, get the valve out of the ventricle, leave our wiring, get everything back, and kind of that would be a nice, easy, straightforward case, and I would not be sitting here with you today giving this presentation if that's what it stopped. So at that point, the patient starts complaining about discomfort. He's hypotensive, 80/50, persistent. There's no significant EKG changes. And all he's saying is, something doesn't feel right. I feel a little off. He can't specialize what is happening. He's not giving us any other clues. He just doesn't feel right. We take a quick bedside echocardiogram while on the table just to be sure that we don't have any significant effusion, because that's what's going to be our first thought, an annular rupture. None of the two are actually happening. And our next step is to do an aortogram, and that's what we see. So for those who might have not seen it, we close the left main. So it's an acute ostial left main occlusion.
So maybe we take a second here and maybe go through our panel. Anyone who wants to tell us what to do with this? I know, Rick, that you do. Taver or Rajiv, anyone wants to thoughts about what to do next?
Yeah, I think you've given us PTSD. I think anyone that's experienced this before, so I need to calm down for a few minutes because this is bringing back bad memories, right? And I think just a sidestep, it's one of the reasons why we're very, very high balloon expandable users, and self-expanding. I'm sure you've been through this. Actually, on your aortogram when you were positioning, there was probably not any flow into the left main. You probably scrutinized that. Could that have been a clue for a recapture? We'll go back to that. But these are a nightmare. I know you must have an algorithm of trying to get in there. One of the bailout is to put 2 snares and pull the valve away. But I'm going to let you talk some more.
I'll walk you through that. What do you think is happening? I guess that's the first, because our first question right now is like, yes, we know that the ostium is closed and we're planning on opening. How did that ostium close was the first thing. Our coronary heights are good. So we're not worried that the native leaflet actually closed. We had like at least 14 millimeters. Our valve depth is pretty good. There is enough space in the sinuses, so you can see the sinuses are filling. So our thought at this point is we embolize with something. And the question is, what did we embolize with, and how can we save it? So fast forward, that's kind of a little bit what we chatted about. So what's happening is that there's an acute occlusion. So what caused it? Is that thrombotic material? Is it a leaflet? And then as you start thinking that, you also need to start formulating your strategy of how am I going to open it? And what are we going to do? And there's a lot of things that come into play, whether that's an acute occlusion or whether it shows up as a STEMI like 5 years later, or whether that's like a patient that comes with an STEMI. So where is your commissures? Where is your native leaflet? How are you going to reaccess it? What's the stent frame? How are the valve heights? Are your sinuses of Valsalva big or not? And you start kind of building up your strategy on what's my guide support, what's my wire support, do I need an aspiration device or not? And this is an acute occlusion of left main. So do I need mechanical support? Is my patient stable enough to tolerate everything that I'm doing? And there's different types. I know a lot of you are not doing TAVRs every day, so they might not be really familiar with what TAVR valves are. But when the patients show up after a STEMI, they kind of come in with the valve already in. So there's different types of valves. There's supraannular valves and there are annular valves. Different designs. The main concept of most of the valves is that the upper part, they try to keep like large cells. So they try to allow for at least a 10 French catheter to be able to engage through the coronary. The problem is that a lot of the times that cell does not fall right in the middle where your coronary ostium is, and that's what gives you problems. So you might have the stent frame actually partially blocking your coronary access. You can have a commissure of your actual valve blocking it, and you can even have the native leaflet blocking it. And there is this concept.
I'm sorry, maybe 1 second. So who was going to put ECMO here? Who's going to call for ECMO? All right. So who should put an impeller? I know you have a fresh valve, right? I mean, I don't know if putting an impeller is a good option here, especially self-expanding valve. I don't know.
Well, that was going to be my question. When you do TAVR, do you have the ECMO circuit all primed and ready to go in the room, or how do you do it at your hospital?
So we kind of have the ECMO machine in the room. We don't have the perfusion. So we've kind of converted to an emergency, pretty much, like as any coronary other case what we do. So if we need to put ECMO, we already have the large bore access there. So we actually thought about putting ECMO. Putting ECMO was not a hard point at that time. The only reason we didn't do it is that he's still talking to us. And that's like the awkward situation where he's hypotensive, but he's stable enough to have a full conversation with us and like kind of keep going. So we thought that if we can open it up quickly, we might protect ourselves. So we call for ECMO team, but on the same time, we're not sitting on it. We're like, let's open it. He's still chatty. He's maintaining pressures. We should take advantage of it.
So I did notice, but there are a lot of collaterals from the right because this is not going to last, right?
100%.
Yeah, and second question, how do you know this is not a valve leaflet?
So the height is pretty high. So we know we have at least 14 millimeters.
Okay.
So we know that the native leaflet, anything more than 10 millimeters is a safe zone. So your native leaflet would not come with that high. It wasn't also either a lot of calcification. So we kind of felt that a small calcium chunk from the left coronary cusp should not be blocking it because there was not a lot of calcium sitting there, which although it's a possibility. So it's not, at this point, we don't know what's really causing it.
And I assume you gave heparin and everything like
Yeah, so ACTs are more than 250. We check them before we even introduce the valve, so we're pretty confident that everything is looking good.
So just a question, I would walk down a little late. Did you pre-BAV this?
No, we did not pre-BAV.
Okay, and then, I mean, if this happens to you, I know it's a differential, is it the cusp or not, but people are not very experienced, right? I mean, is this the right time to make a differential, or should you be moving to something quickly? Obviously, you tell us about the story, but And people who are do you call for help at this point? Do you call the surgeons to open the chest? I mean, how many people would call the surgeon to move on?
You know, I think getting the ECMO ready is very important. But as you said, he's still talking to you. The STs are not yet up. He's not even having chest pain. So it really makes sense to quickly go forward with a supportive guide, because I think if there is leaflet obstruction, then you're going to need support. You're going to need some advanced wiring.
For sure. Yeah, and I think I agree with all the, like everything you.
Yeah, I concur. You know, the patient's relatively stable. You're ready, just get the guide in there and get a wire down and get flow. Of course, call for help.
Yeah, I guess I'd differ a little bit. I'd be concerned that you're in a window here where that may not last, sort of what Vlad alluded to, and that, and I don't know your scenario, but in our institution we could get on ECMO pretty quickly, and I think I would take those first few minutes, get on ECMO, and then from the other side come up with the guide and do your thing.
Well, our strategy is call for ECMO, because we all know that ECMO takes a few minutes until you get your team in there, and open it up. And so just quickly, commissural alignment, what it is pretty much, and that's what's going to be your troubling whenever you do a case which has a valve, is does the valve new commissure actually sits similar to what our native commissures are, or is it right in front of the valve? So our coronaries are not on the commissures. That's how we're like born with. But when we put a new valve in, if we don't achieve commissural alignment of some degree of commissural alignment, then you're running the risk that you might not be able to re-engage your coronary. And a lot of the valves these days have actually changed their practice, and like in their new iteration, we become better, become smarter, and we start like giving more attention to that. So that's for people who don't do TAVRs, that's what we're dealing with. It's a CD8 model, it's not the reality, but that's what we're dealing with. You have a valve which sits in the annulus, a few millimeters below the annulus. You have your sinuses, and you have your left main, which should be open. So that's what ideally you should be happening, and you see your top of the valve, because it's a CD model, it doesn't get compressed, it's covering your whole aorta. So what we did is we engaged our coronaries, we brought in an EBU 3.5. There is different catheters. I know there's people out there that talked about JL 3.5 guides. There's people who do XB 3.5. And there is data actually, the majority, like in some of the trials, the majority of the patients are actually being done with JLs. Having said that, it's not 100%. So if you're feeling comfortable with another guide, you can try it. We wired it with a whisper wire. We were lucky enough actually to be able to, and you can see there's a little bit flow left, so we were able to go behind whatever was embolizing the ostium of the left main. We ballooned it with a 2O balloon, making sure we can restore flow. And you can see that below the left main, there is something sitting there. So patient is stable at this point. We go ahead, we post-dilate. We IVUSed. I apologize, we don't have the IVUS because that was on a hybrid room, so I don't have the pictures because it was a portable IVUS, but we did IVUS. We sized it. We used a 4.0 stent. We post-dilated with a 5.0. And as you can clearly see, there is perfect flow down the left main and the LAD. And you can see something like a S-shaped material sitting at the sinuses.
So tell us about your stent. How far back are you with
So we entered a few millimeters back. We did not want to cross inside the valve. We knew from the model that I showed you that your sinuses are actually large enough to allow for a few millimeters of your stent to protrude outside without really interacting with the valve frame. The reason we did that is because we didn't really know what was closing it. So we wanted to achieve that compression of the ostium of the left main.
But it's not a big chimney going
No,
all the
no,
way
no,
back.
we didn't do a chimney, exactly. So it's only a few millimeters. We're not worried that we actually occluded the valve with a native leaflet, like just extending all the way up. We just want to, whatever closed the vessel, we want to make sure that we have enough radial force to not allow it to just shift back upwards. And I'm sure everybody has the curiosity of what this was. And that's why we get CTs. So that's a CT from a 30-day follow-up. You can see the valve is perfectly sized, working great. And at least based on what the material looks, it's not calcified. We think it's a teared leaflet. So a part of the leaflet during one of the recaptures or during the positioning or at any point broke off and embolized the ostium of the left main. So you can see our stent, it extends a little bit inside the left main, inside the aorta, but it's definitely not interfering with the frame of the valve, and it doesn't really affect the function of the valve. So with that, a few key learning points. Patient did great, discharged home. That's more than a year-old case, and patient is doing well. He didn't have any issues with his coronary stent. So coronary access after TAVR is increasingly more common. You will be seeing it more frequently. We're doing TAVRs in younger patients, so you should expect a 60 or a 70-year-old that got a TAVR at some point. You will need to reaccess those coronaries, so you gotta be a little familiar with the valve, and also there's a lot of different small techniques. You gotta strategize before. You gotta know what's in your toolkit. So what's your guide? You might need guide extensions. Your guide might not sit perfectly because you might have a strut. You might have a native leaflet. If it's a valve-in-valve, you might have actually two different struts hitting between the two where your coronary is coming. So you gotta be prepared that it might not be your straightforward case, and use anything that's coming on your toolbox so you can actually engage the coronary. And from that, the valves are getting better. The valves, they have larger struts. Some of them have now bigger boxes, like Evolutive X Plus comes with a bigger box. I know the X4 from the Edwards team is actually having commissural alignment. So we are getting better. But some of the patients you'll see will not have the latest valve. So they'll have your older generation valves, and they might have not been deployed with commissural alignment. So you gotta be ready for to use your toolkit so you can actually.
Perfect. And the patient stays stable through all this and sailed away. So
yeah, patient got discharged home actually the next day.
yes.
Can you comment on choosing the EBU guide versus JL guide in a core valve?
So it was that's actually the guide that we were more familiar with for our coronary interventions. We felt that we're going to be able to deliver it pretty reasonably. There is data that in a lot of the studies that JL4 was the catheter preferred. Having said that, there's no data that the one does not engage versus the other. So you have to be ready to use a different guide if need to. And you also have to be ready to pretty much bring your catheter deeper with your wire, and then as you pull back your wire, get advantage and engage your coronary. So I think that you gotta be using, at least my advice is use the catheter that you're most familiar with on how it's gonna behave, and then be ready to adapt as needed.
Wonderful. Thanks again. Thanks so much. Excellent case.
Thank you.
All right, and then we'll go on to Dr. Gulati. There's no one better in the world to present on what is often a nightmare for people in the cath lab when you go in and you realize, or maybe you don't realize, that the patient has a spontaneous coronary dissection. Rajiv.
Manos, thank you. So everyone will look at this and see if I'm bluffing or double bluffing. The title is SCAD, and maybe I can ask the panel what the diagnosis is. Typical ACS, non-STEMI. Am I allowed to turn backwards? I'm going to turn backwards.
So, I'm sorry, the question is...
What is this? What is this?
All right, who wants to unmute any? What do you think?
Well, if Dr. Gulati is presenting a case of SCAD, I'm going to say SCAD, but it looks like hazy, a classic ACS. Now, I don't know the history, but 43-year-old female, this could be type 2 SCAD.
I'm so glad you didn't know for sure what it was. Kechi?
Yeah, I agree as well. But a couple of things that will make me think there's no, the other vessels, a little bit some tortuosity, and there's no real atherosclerosis in some of the other vessels. So SCAD would be on my differential. Yeah, go ahead.
Rajiv, one other thing that really catches my eye, you see how the proximal LAD then suddenly starts tapering? That's very suspicious of an intramural hematoma.
What about the IVUS? I don't think you can tell. I mean, this is a digital IVUS, and that's, for me, the learning point of diagnostic IVUS. The digital IVUS is really hard to discriminate. Plaque, that could be a snowstorm or plaque, from intramural hematoma. What you need to do with a digital IVUS is to take your click wheel and scroll a few frames down and a few frames up, and I guarantee you at some point you'll be able to identify the internal elastic lamina, the back line in between there. And when you see the IEL, if the lesion is outside the IEL, it's in the media, therefore it's an intramural hematoma. So this is SCAD, but the learning point for me, and I think trying to convey this, is that digital IVUS is notoriously hard to make a diagnosis of SCAD, but you can get it if you sit down, take your glasses off, scroll frame by frame to identify the internal elastic lamina. So diagnosis in this case was SCAD managed conservatively. So if you have the luxury of a choice of intravascular imaging, the two options on the right are your best. The rotational eye, as you can see, the IEL is very visible. That black line in the middle frame, and of course OCT, a great big hematoma causing compression of that lumen. So if you have a choice, I'd choose one of those two middle ones. And I put the point on the right is you don't need to inject a full 15 cc's and image the whole vessel. You just need like 1 or 2 slices. This is a biopsy you need to make a diagnosis. You're not trying to assess lesion length, etc., etc. Question now is just as a side note here, whether you need to do contrast at all with OCT. This is a lateral non-STEMI and a diagonal indeterminate lesion. And I'll just throw this out there as a consideration. So the top panel is the diagonal. We did a run without contrast, that's the top left. A run with contrast, that's the top right. You see the top right, the lumen is cleared. But the question is in the top left, do you buy that is an intramural hematoma even without clearing of contrast? I think it may be somewhat compelling, and you compare it to the normal vessel at the bottom. I just throw that out there that it's possible, and we'll collect a series and try and get this published, but it may be you can make a diagnosis because you don't need to clear contrast from the media because there is no contrast in there. That's intravascular imaging, but really, most importantly, you don't need intravascular imaging in the vast majority of cases of SCAD, right? Distal, tortuous, nasty vessels, this you can all see is spontaneous dissection, and I would resist the urge to image this vessel. Why deliver a bulky catheter down this tortuous vessel? You have a diagnosis right in front of you. So when should you do intravascular imaging? And I will say the only indication is when you have a proximal to mid lesion where you think you can get a catheter down there, and the lesion is indeterminate. So the lesion on the right, these are all young women, you'd all buy SCAD based on their history. The lesion on the right, you can see there is, where the arrow is, there's an intimal dissection plane. I don't think you need to do intravascular imaging there. You've got to diagnose a spontaneous dissection. The other two, you just don't know. And if you do image, you'll see that the two, the one on the left and the middle one, they were both diagnosed as SCAD elsewhere. They were left at home for about a month and a half with terrible limiting angina, came back, had imaging. This is atherosclerotic plaque, got stents like we do every day, and got better. So image, proximal to mid, and indeterminate lesions here. Comments, thoughts? All right, we'll move on to the last couple of minutes, maybe some key points on treatment. This is a young woman who had a VFib arrest and an anterior STEMI on her ECG, and you see an occluded mid to distal LAD. Hands up for, and this is SCAD, I'll give you that. Hands up for managing conservatively. Maybe an audience play here. All right, so the third of people. And chest pain, ST elevation, which is settled, and VFib. Hands up. PCI, but the right way. So right way PCI, about a third maybe concern. So again, there's no data. My biased opinion, if someone's having a STEMI, I think you've got to get it open. So I think this conservative therapy in SCAD is all well and good when you've got normal flow at baseline or TIMI2 flow. But if you're occluded, you've got to get it open. This is a STEMI. So this is balloon angioplasty, and this is ventricular fibrillation after balloon angioplasty. You see that? VFib. If there's fellows in the audience who have not seen VFib in the lab, this is what it looks like. And this is the result here. So we see good flow. We see an unraveled intimal dissection flap over here. And I don't think you need to stent this. We haven't published it yet, but this is a very low risk of acute thrombus. This is not like plaque dissection where you'd be worried it's going to be a nidus and you're going to stent it up. You can leave this well alone. Now that intimal flap may stay there for the long term, and late angiogram may not tack up, but the patient will do very well clinically. And I don't think this should be stented. Balloon angioplasty alone is a very reasonable option in spontaneous coronary artery dissection.
So, Rajiv, quick question there. Sometimes guarding this is extremely challenging. What is your threshold for just knuckling and pushing like the last session, or would you rather try to go through?
I think exactly that. I think I would try tip first and maybe parallel wiring, some 1990 CTO sort of techniques, but if there's any concern and the patient's having a STEMI, I would mongo knuckle down there for sure.
I think there's a question there. You mind getting the microphone to Dr. Boufadel?
And with balloon angioplasty, would you just do regular balloons? There's some talk about cutting balloon, trying to hematoma.
Yeah, so the next slide, the torque cutting balloon is all very good theoretical. It comes from the CTO world you spoke about. And in the CTO world, it makes a lot of sense. You've got calcium plaque, hematoma. It makes sense to put blades down there. I think you should be reluctant to put blades down these young women, fragile, tortuous vessels. And these are super fragile intima. In fact, here's a study we did OCT. You see the actual intermedial thickness at the point of maximal IMH is so trivial that a balloon alone will, I guarantee, low pressure 1-to-1 or 1.2-to-1 will fenestrate that vessel. So I think it is safer to do a balloon alone. Stents can work, yeah. Go ahead.
Rajiv, quick question. Regarding the balloon angioplasty, what's your strategy? Shorter balloons, longer balloons, undersized long balloons, long inflation, what do you do?
Yeah, so there'll never be a randomized trial, but I would say a 1-to-1, relatively long balloon. I wouldn't be too worried about causing damage up and downstream. You don't quite know where the point of maximal occlusion was. So in that case, it was a 3020 balloon. Just a short inflation, 10 seconds or so. And you can always do more. Yeah, the medical therapy after a spontaneous section, no one knows what the right answer is. We've taken the position we're going to do a long lecture, but a single antiplatelet therapy and no statin if the lipids are normal. We will give a beta blocker because it may reduce recurrence. Final, this is a case from elsewhere. SCAD and TIMI-3 flow, you don't need intravascular imaging. There is intimal dissection flap. I think in the modern time, I would manage this conservatively and watch the patient in-house for 5 days because of the risk, about a 17 to 20% risk of extending in that 5 days, and then you'd balloon angioplasty. But I think you give it a conservative therapy a chance. But I wanted to show this because stents we're all very used to in the plaque world, but stents and intramural hematoma behave differently. Sometimes fantastic, but sometimes they cause complications. 3 complications in this one case. First, you see the stent was placed, and you see how the intramural hematoma is toothpasted downstream. You'll see that. So now flow is reduced, and this high-grade stenosis all downstream. The stent itself looks spectacular. An attempt was made to put a stent through the first stent, and that first stent is not well anchored because it's IMH. Guide extension was used, and it squished that first stent, so longitudinal compression and distortion of the first stent. Second stent was advanced and got flow down there, but you look, it's a little bit uncomfortable, right? It looks a little bit messed up and squished. And 6 hours later, patient had stent thrombosis requiring emergency bypass grafting. So that's just a single case showing how stents behave differently, not always, but differently in spontaneous dissection. So the key learnings, I think angiography alone suffices in most, an infrequent need to do intravascular imaging, but if you do it, especially digital IVUS, scrutinize it carefully. And I would strongly urge for balloon angioplasty alone in occlusive SCAD. Thank you.
Some questions from the audience?
Yeah, once you, I agree that you have to restore flow if it's a STEMI ongoing pain. So once you get wire, do you IVUS those to make sure you're in the true lumen? Because you could put a stent in the architecture and have a problem.
Yeah, I don't know is the short answer to that question. I mean, sometimes you can just tell, you're finding multiple septals, or if it's a workhorse while you just know. And, trying to scrutinize an IVUS down there in the LAD in the middle of the night, you can maybe make mistakes on that. So I think, yes, if you're really in doubt, but usually you know if you're in a lumen.
Which circumstances, if any, are you bringing these patients back that you've conservatively treated or that you've done balloon angioplasty alone and let heal?
Yeah, it's a great question. So we've gone like in a sine wave back and forth about surveillance angiography. We've currently settled on doing a CT before they leave the hospital and may do a CT in follow-up. I got to say, it's not really giving us that much patient actionable information, but that's what we're currently doing.
Yeah, I can emphasize more on point you mentioned about keeping them in-house for a few days. We had a young lady 1 month postpartum. When I was a fellow, she had OM, actually dissection. When she came in with lateral infarct, we decided to manage conservatively. Day 3 in the morning, she was absolutely chest pain free for the whole 3 days. We were about to discharge her. She started having indigestion again, and now anterior STEMI, and she was actually propagated to whole left main, ended up having actually emergency bypass. So I have a question for you. How aggressive you look for FMD in these patients? Do you check the femoral, carotid, duplex? Do you have any screening plan for FMD?
Yeah, I guess at 2 points. First, your observation of having to observe them is crucial. If you really want to finesse that observation period, we recommend 5 days. You know, that it does burn out after a few days. The 3 predictors of extension are intramural hematoma in isolation. So if there's an intimal flap, that seems to be protective. It may have decompressed. That sort of makes sense. And the second 2 and 3 are SCAD burden. So degree of stenosis and length of SCAD. So high SCAD burden, IMH alone, they're the ones that are high risk of extension. We screen routinely FMD. I've done about 1,500 CT screens now. And there's an extravascular abnormality or FMD in about 60%. As of now, it has made no difference in predicting risk of recurrence. So I am honestly, you know, I'm questioning whether we should be doing this in the long term.
And then while they're going to, one question that comes up, if a man comes in and the coronaries look like this, do you, I mean, I know it happens, but what is your threshold, and you do things different in men versus women with typical angiographic appearance?
Yeah, I would really question the diagnosis in a man. Question and question and question again. And they're the ones I would go, further and further to try and solidify diagnosis. Because true female type SCAD that I showed you is pretty rare in a male. The male ones we see, I think, tend to be a little different. The weightlifting, the intimal dissection flap on exercise, that may be a different pathology. You will see some males like this, but as you know, this is extraordinarily rare in males.
We published a small series of STAR for SCAD, and the indication was actually exactly these cases. And I had a case that it's not published, but the patient had a left main dissection. It was turned down for surgery. She was 39. And I did this case last year, and I think what has emerged is the suo wire is probably your best wire for wiring the true lumen, because it's non-polymer jacketed. Polymer jacket tend to get into subintimal space, whereas this one actually is so if you buckle, it's because you're not going to true lumen. And then the suo, and there's a series from some Italians who've published that the suo for dissection, especially for either iatrogenic or SCAD, is very nice. So I did that. And second, once you've established your true lumen, I think stenting has not worked in the past because we didn't understand properly the pathophysiology. If you evacuate the hematoma, if you release the hematoma, then you have the option to stent or not afterward. And I think when you've established your true lumen wire, then you have multiple options. You can go into the false lumen, you can aspirate blood from the false lumen, you can star down because you have protected your LED. And in that case, with the left main dissection, I was able to do a 2-stent strategy, fenestrate everything on an impellant. She survived. But the point I wanted to say is that I think traditional stenting was just plain wrong. You're just pushing an hematoma distal or proximal, you're shoving branches and everything. And I think the key element is to evacuate the hematoma in some way. So maybe ballooning is enough, but I would say that what has been published is also the cutting balloon. I know you may be lucky and just a balloon may do it. But if it doesn't do it, what's your next step? It's most the question, right? If you still have a TIMI zero flow in the distal LED, you gotta do something. You may be in the true lumen, but if you're not in the true lumen, how can you do? Well, you said, you may be a Mongo and you push it down and you fenestrate, because it's in all cases, you can actually restore flow. I tell you, this is relatively easy.
That's fantastic comments. So really great learning here, and I can't disagree with any of that. I would just extend your comments by saying I would be reluctant to stent in that distal to mid LAD, having seen so many cases of refractory problems, months and years down the line of undersized stents, restenosis, and fracturing because it's a very tortuous vessel. So Stefan, thank you for your comments. Yeah.
All right, so last question, I'll go to the next one.
What's the pharmacotherapy for unstented patients?
Unstented?
Yeah, patients who recover, what is the medication you give them?
I would say aspirin alone, and you can make a case for no antiplatelet therapy, beta blockers because it may reduce recurrence, and avoid a statin if the lipids are normal. That's what we do.
Wonderful. Thanks again. Thanks, Rajiv. That was excellent. And We're going to continue to the next case from Dr. Shunk, who's going to talk about bypass grafts and challenges about how to approach the bypass grafts. Again, so if you see a SCAD case, please feel free to call Dr. Gulati. His cell number will be on the program.
Thank you. Let's see. I can advance the slides here. So this is a case, it will have a little bit of overlap, but I'm glad it won't have much with that first case. But this is a case of an 83-year-old man with a remote history of CABG, severely depressed left ventricular function, and has severe AS with low flow, low gradient. And he's presenting with increasing dyspnea. His pertinent history is a CABG back in 2001. He had a lima and 2 vein grafts, and they were a little bit unusual. So this is the diagnostic cath from the outside hospital right before this current presentation. The native right is occluded. The vein to the right is occluded. You see the stump. The left system, the native left in the REO caudal, shows a fairly large circumflex system that shows a right coronary system that's collateral dependent from the left. You see competitive flow in the left, and we'll sort that out in just a second here. But you can see here in the REO and cranial, the LAD here has actually 2 branches that are grafted. There's competitive flow from both. And in fact, the old film turned out to be pretty invaluable in sorting out what was grafted to where. And again, the right system is fairly large and very collateral dependent. You see an epicardial from the circumflex to that right. In the spider view, they were concerned that the distal left main looks hazy. It's not the best angiogram, but it's hazy. You see the competitive flow in the LAD system. You see the very large circ system, maybe some more distal disease too, but mostly concern up at the left main ostium, and again, the right coronary collaterals. So this, again, this vein graft, we weren't sure where it was going initially. It's going to a diagonal, and there's another, turns out there's a lima to another diagonal that looks very similar, and this is where the old film was very helpful in sorting it out. Apparently during the surgery, the initial surgery, they felt the LAD was not a good target, and they put the lima onto the D2, and they put the vein graft onto the D1. And I just put this here, this is mainly for the fellows in the room, because fellows will speak as if anything done more than a year ago is just lost to history, and there's no way of ever getting it, and it's on stone tablets somewhere. But in fact, the old films are often available, and you can find them, and they can be really useful. And you can see here there's a D1 and D2 that come off almost at the same exact spot, and that helped us understand why the LAD never was grafted. The D2 has the lima, and a vein goes to the diagonal. So what we have here is a patient with an occluded native right, a vein to the right, very collateral dependent inferior wall. He's got a patent lima to D2, patent vein to D1, and there's concern at the distal left main and circumflex. And
so Rhian, what would you do in this particular case?
And he presented with unstable angina, or was this just an
accelerating failure to thrive and shortness of breath. Okay. It's not so much chest pain.
So I think in that situation, interrogating that left main into circ a little bit better with either IVUS or OCT and see kind of what's going on.
Exactly. So he was referred over with an idea to do IVUS or something to look at that. And my partner actually did this cath, and all he had to do was a really steep, good LAO caudal. And you can see that there's something that was either hiding, I think it was probably all hiding, or possibly rapidly progressed from the time of the original diagnostic cath, because that circ is super tight, and the distal left main is super tight, well, pretty tight. So what would the plan be? I'm going to put the clinical challenge here is we have severe LV dysfunction, severe aortic stenosis with low flow, low gradient, occluded right, occluded vein to the right, a critical stenosis in the circ that's ungrafted, and the question possibly rapidly progressed. And so
maybe we just go from there. So Vlad, what is your thought?
Well, severe LV dysfunction, you have a huge ischemic burden in spite of having 2 diagonal grafts open, and you can get into serious trouble here. So I think MCS is for me, a given here, probably Impella, and I think you need to wire both branches, pre-dilate, IVUS, and then deal with that. IVUS, most likely IVUS, and then deal with it with whatever the imaging shows you. Plaque modify if you need to. The ostium tends to be calcified even if you don't necessarily see it on the angiogram in half the cases of left main bifurcations. Probably worse post-bypass. Calcified nodules tend to exacerbate post-bypass because of changes in flows. So you may need quite extensive plaque modification strategy here.
Sure. Rajiv, would you do the TAVR first?
Yeah, what a great question. Probably do the coronary disease first right now, but that's very debatable, I think.
I would do the TAVR first after the most recent data published. Maybe if this case was a year ago, I would do the PCI first, but with the most recent data, I would do the TAVR first and bring him back for the left main circ PCI if needed.
Sure, it'll be a little harder, but sure. Kit, what would you do in terms of either TAVR or PCI and support or not?
Yeah, I plan to treat that left main bifurcation. Support's going to be an issue because of that severe aortic stenosis. Crossing the valve will be tricky. But yeah, I'd go with PCI first.
Yeah, I guess a question I have is there any progression in his aortic stenosis severity that explains his symptoms, or do we think it's all left main progression? I think it is left main progression and circ progression.
That was our impression, yeah. I mean, in fact, the gradient's been dropping across the aortic valve because the EF is dropping, but it was our impression also that the circ was the main thing changing.
Yeah, so in that case, I'd go for the PCI first.
So great. Actually, you guys, that was a great discussion, and I actually just threw up some of those as multiple choice for everybody. So those are, find another surgeon who's willing to do CABG and SAVR. I don't know if you guys have any surgeons who would take an 83-year-old in this situation. I don't. PCI of the native circ and left main, we heard several people say they would do that first with Impella CP support or some kind of support like that. I didn't hear anybody say they would do the CTO. I'm actually kind of glad to hear that in this setting. Or some combination of B and C, so doing both of those vessels with support as long as you got the Impella in. Or proceeding directly to TAVR, or call your friendly comfort care, colleagues.
Does BAV have any role here, either for helping with support or to help the aortic stenosis? Balloon valvuloplasty, would it have any role here?
Yeah, I think that's a really good question. I mean, theoretically, it can get you through a tricky PCI or through something else, but I think in this day and age, you have to be prepared to put the valve in if you have aortic insufficiency or something. At least that's been our practice. And so, I mean, the final option is get called for jury duty or test positive for COVID or something. So we had our heart team meeting, which is, I liken it to a Ouija board where everybody has a little input, but nobody's really calling the shots. And we decided that we would do PCI, this plan for PCI, we would use support, we would use ECMO for our support, and we'd combine it with the TAVR. And I know this isn't feasible in a lot of centers, but it turns out to be in ours, so that's what we opted to do. So we pre-cannulated the patient. We stick both sides, pre-close both sides, put a 15 French cannula in the right femoral artery, or sorry, I put right, I meant left, and a 23 French left cannula, and then we go up. And I took this first shot. Now does the plan change at all? Does anybody? So just in the few days, I think it was 3 days from that prior cath to now, there's no flow in the circ. Essentially no flow. and you've got the whole TAVR team waiting for you to do your thing, right? So
what do you do first, the TAVR or the PCI?
So we went on ECMO, and we decided to do the PCI first, thinking it'd be easier without the valve in our way. And so, in fact, there was some discussion about using guides. I won't belabor this, but we couldn't get an EBU to sit in there. We had to actually put a 125 JL through the EBU, engage it that way to get a little upward direction, and then pull that out, and after getting the wire in. But that can be helpful sometimes in post-TAVR PCI also. So we got in there, we got a safety wire in the LAD, we got Corsair, tried to get into the circ with just simple workhorse wire, thinking this must be fresh, and it wouldn't go. So we started to escalate a bit as if this were a CTO. We got the Fielder XT, it wouldn't go. Due to the sharp angulation, we thought maybe the Gaia third would help to be able to directionally steer there. It wasn't where we wanted it to go. Tried the Mongo, the slippery approach wasn't really working. And then we get this picture and we've got, a storm cloud already. So we've gone with the pokey wire, and then we've got a storm cloud. And this wouldn't, this is something all the CTO operators are used to, but not with anesthesia and perfusion and surgeons and everybody breathing down your neck, tapping their feet. When are we going to do this TAVR? So anyway, we escalated more with, used the Mongo, used a Confianza Pro, and essentially got to a point where we felt like we'd sort of fenestrated the whole thing, like a star, essentially. And I know not everybody likes to do tip injections, but again, we don't have contralateral access to be able to visualize this, so we just did a tip injection, and you can see that there's dissection, but there's runoff. There wasn't runoff to start with. So we're relatively happy with that at this point. And we left this as essentially a star result with fenestrations, and then proceeded and put the valve in. Patient weaned off the ECMO, we percutaneously, the perclose is closed, and it was relatively uneventful. I do actually have a follow-up because we wanted to look at this again. Sorry, I thought I had it in there. Guess I didn't. Oh, sorry about that. Anyway, we did take a look, and it actually was still patent and looked pretty good on follow-up. But that's how we managed that, and I would take any questions or comments.
Perfect. Thanks, Rick. I mean, that was. I haven't seen any other combined PCI TAVR with ECMO. That's pretty cool. Anyone in the audience who has seen or done that? All right. Well, welcome to CVI. So now you can go home, and next year we'll have a lot of case series. But no, I think this is an amazing case, and I think that was a great solution. Actually, you have the stability, and usually use impeller, right, for support. But in this case, with the TAVR in place, that will make the most sense. Yes, Ivan.
Just wondering, did your TAVR team say this was other than the EF and coronary disease, as far as the anatomic feasibility to put a TAVR in? Because it seems to me, I agree with your panelists, that TAVR can be pretty straightforward if the anatomy is okay, and rather than balloon valvuloplasty, just unload the ventricle by putting a TAVR, and that would be maybe something I would consider doing differently.
Leave the coronaries,
or just do the TAVR first, because you just take that off the table. If it's a straightforward TAVR, if the anatomy is fine, if the axis is fine, if the angles are fine, it's going to be like a 10-minute TAVR basically.
Oh, you're saying after you're on ECMO, then do the TAVR first?
Or no ECMO, yeah. So that would be just the only comment if it was.
Yeah, I kind of glossed over the TAVR parts of it, but it was a relatively straightforward 26 Sapien 3, case. There weren't any particular watchouts on the valve.
So I wouldn't have ECMO in my center because they just wouldn't do it. But tandem would probably work here as well, I suspect, and so that would be another option.
Perfect. Well, again, thank you so much. Phenomenal presentation. We'll go on to Dr. Allana, who's going to talk about a case of In-Stent Restenosis. We already touched a little bit on this subgroup. Salman, thank you so much.
Thank you, Manas and CVI, for having me. It's a pleasure. It's a great conference and a great opportunity to share a case that I was involved in treating.
The big green button.
These are my disclosures. So we have a 72-year-old man who presented, who had history of coronary artery disease, had a PCI to the LAD about 2 years ago. HFpEF, hypertension, type 2 diabetes mellitus, came in with NSTEMI, has a neuroendocrine tumor with chemotherapy, and his EF is 45 to 50%. He was referred for coronary angiography for NSTEMI, and these are his baseline angiograms. You can see that he has severe left main disease and distal left main disease, possibly extending into the proximal LAD, and most remarkably, there is a stent in the LAD that is severely underexpanded. It was placed 2 years ago, and patient surprisingly did not have an event with that. So these are another projections. It shows LAD stent under expansion and severe left main disease. And right coronary artery had severe disease in the proximal and the mid segment. So patient was having intermittent chest pain. We decided to put a balloon pump at that time called CT surgery. And patient was deemed high risk for CT surgery and therefore came back for PCI. It was straightforward PCI of the right coronary artery. FFR angio was 0.73. 3.0 by 38 millimeter drug-eluting stent. Final angiogram got a good result. And subsequently turned our attention to the left main LAD. So you can see wired the LAD and wired the circumflex. We did IVUS, and there was severe underexpansion of that proximal LAD stent with a minimal luminal area of 1.7 and the mean, minimal luminal area of 2.4 and a minimal diameter of 1.7. So at this...
Is one stent layer or two stent layers?
One stent.
One stent.
So maybe we can talk over here. So Ami, what would you do?
You know, what I've done for undersized, underexpanded stents like this laser, I've done quite a bit. And I think in my experience, the laser, especially if done with contrast, gives us the opportunity to re-expand these underexpanded stents. But there is also a risk of slow flow and with laser contrast. You have to be patient with laser though.
I usually start off, first of all, using a non-compliant balloon and see if that works first. And if that doesn't, then I escalate to other therapy.
Shockwave, if it doesn't work, then laser with contrast.
Yeah, the problem lesion though is in the left main. We'll talk about that in a second. But I think for these single stent underexpanded, honestly, I think anything can work. Potentially IVL, laser contrast, OPN. If you need to burr it out, all of those. The thing you must never do is put that second stent in, because that's when Brilakis gets these referrals with 4 stents in there. They're the ones that are not going to expand. So the single stent, you should be able to get it open with one of the new techniques that we have.
Yeah, I agree with Shockwave for sure. Plus minus Rhoda if needed, but I think Shockwave will soften up that calcium and will allow you to expand that stent better.
Great.
Yeah. And now that we have DCBs on our shelves, we can adjunct that at the end of the case. Just getting
Great.
through that.
Yes.
Moment where I would say I would use Rhoda is because you're gonna need a lot of things there, right? It's not gonna be a one modality. Oh, I'm so happy I've ever expanded with laser. But here, if you want, it's where Rhoda can really work with a tool burr, because you can shave this off and then afterward escalate and do other things. If you start ballooning and everything, then your Rhoda may not work as much because you won't have as much contact with your burr. It's extreme burring. It can be difficult. If you're not used to do Rhoda, don't do it in these cases because you may have burr trap, but it's certainly an option.
Yes.
At this point, I want to emphasize one thing more. We have 2 accesses from the femoral artery and severe calcification here. After attempting such kind of device-related interventions, then the risk of rupture is so high. So we have to prepare for one more access before attempting to just prevent it. Because if you fail, you do not have time to get a new access because the patient will fail because of the rupture. So just one more access for artery from the radial maybe.
You mean if there's perforation, we can do a ping pong technique. Great points. So we decided to do initially a 3 millimeter balloon at high pressure. It did not expand. And during the procedure, of course, there was intermittent ventricularization of pressure, patient having chest pain. So we decided that we got to treat the left main first. So we ballooned the left main, stented the left main first, 4.0, stent, and then potted with a 5.0. And at this time, crossover stenting, provisional stenting, and got a good result. And so now we thought that we could turn our attention back to the under-expanded segment. We decided to use shockwave, 3 millimeter shockwave balloon, delivered all 80 pulses, post-dilated, still wouldn't expand. Use a 3.5 balloon, shockwaved, and at 3.5 balloon NC at 26 atmospheres, still under-expanded. So we thought that, this is our angiogram for now. We were supposed to have an OPN balloon in about a week. We thought we'd bring the patient back and try the OPN balloon. We had already did shockwave. So called it a day, brought the patient back in a week. And again, the under-expanded LAD segment. You can see the IVUS, the left main stent looked good, but severe under-expansion of the LAD stent that was previously shown. So, of course, I'll go over this. We know the Voxman classification. This is a type 1, a mechanical stent under expansion, and we have a lot of tools on our disposal at this time. We've already tried shockwave, but we have modified balloons, lithotripsy, laser. We had tried shockwaves. We tried the OPN balloon, 3 millimeter at 50 atmospheres. Did not work. What do we do next? Yeah, we thought about it. We did orbital atherectomy. We thought the atherectomy would be needed. 125 millimeter at 80,000 rotations and even at higher speed at 120. That's orbital. Yeah, we did orbital atherectomy at higher speed, 120. Yes. So we tried laser. So we did laser. We had 0.9 millimeter catheter, and we did laser with contrast. Did multiple runs with laser, as you can see, and still unexpanded. Yes, Mike.
Experience in Henry Ford where we used actually the peripheral CSI at like the solid crown, and it kind of cracked it. So I don't know what you would do next after that.
Yeah, that's a great point, and I think that was certainly we're thinking about it, but I think we're more comfortable with Rota at this time, as Stefan called it. I think we have to turn to Rota at this time.
Did you consider doing nothing? I'm just throwing it out there, right? Your left main was your culprit.
Yes.
They've been fine for a year with this. Did it cross your mind to maybe
just
just throwing it out there?
Yeah, no, actually no. It was like, the patient did not have an event. You're absolutely right. It has been there for 2 years under expanded stent. But it was just, we felt that we had to do something. But you're absolutely right. I mean, that was another option, to not do anything and leave it alone. So as Stefan pointed out, it was the minimal diameter was 1.7, so we took a 2 millimeter burr. And initially started at 160. Usually for stent ablation, you need higher speeds. Quickly went up to 2,000 rotations, 200,000 rotations per minute. Did 5 minutes of Rota, and the Rota did not cross. What do we do next?
Just as a general point, after any one of these therapies, I always go back to non-compliant. So you're sequentially doing it.
Yes.
Laser, non-compliant.
Yes.
Then a new non-compliant.
You're absolutely right.
And one thing that may work is using a cutting balloon at this point. And I think I made this point earlier today. So we cut at much higher pressures with these calcified lesions. Start at 18, go higher up if you need to. But after every one of these maneuvers, just try to stretch it again.
Yes, and that's what we did. We just tried the angiosculpt the first time after shockwave, but after every one of these maneuvers, we tried the non-compliant balloon at high pressure. We did not try the plaque modifying balloons, but did non-compliant balloons after every time, and it was still under expanded. So what would we do now? Leave it alone, or should we do
So
it?
one more comment for Dr. Cihan.
In two cases like that, just entering to the vessel and puncturing the subintimal space with a confianza or something like that, and just coming there with a microcatheter, then creating a space in the subintimal part, and just after that dilating it, maybe it will work.
Yeah, I mean external cap crush. The problem here with the external cap crush, we have a stent extending back to the ostium of the left main. So to really do an external cap crush, we'll have to go out of the left main into the LAD and crush it. So that we didn't think that would be an option. 1.7. Yeah, that's a great point. And so before, and we were thinking about that too, 175. But we decided to go up on the speed to 2 millimeter, use the same burr, it's already there. We crank up the speed a little higher, 225, and burred for a long time. We did atherectomy for about a total of 10 minutes and 53 seconds. And the burr finally crossed. But that was just, it just crossed. We still have to expand it further. Yes, it did. Yes, thankfully. It doesn't. Okay. So now we have, we use a 2 millimeter burr, went back with a 3 millimeter non-compliant balloon, 26 atmosphere, still under expanded. Yes, you called it, Stefan. So we did OPN, 3.5 millimeter balloon, went up to 50 atmospheres. Finally, the lesion expanded. Got a good angiographic result, and did IVUS, showed a good expansion of the stents. We did not re-stent, and I think that's one of the questions that I could ask panel in these kind of situations. Would you re-stent it? Would you leave it alone? Based on everything, we decided to leave it alone and not stent it. So overall, lesion preparation is extremely important before stent expansion. Under expanded stents can be very resistant to expansion. Prevention is key. For treatment of under expanded stents, multiple modalities may be required, and avoid atherectomy in recently placed stents, but it can be used for older stents. And sometimes can be very, very helpful, especially in these kind of circumstances. Thank you.
All right, thanks again. Thanks, Salman. Again, great case. I guess patience pays off in the end. And moving on to Dr. Srini Potluri, who is going to talk about PCI of a left main lesion.
Thanks, Manos and the CVI team. Great cases have been presented. So I'm going to talk about the left main intervention in one of the patients. So we have a 60-year-old obese male patient with hypertension, AFib, sleep apnea, and diabetes. He came to the outside hospital with a non-STEMI with chest pain and shortness of breath. EKG showed AFib with RVR and new right bundle. He was initially stable, but later, while he was in the hospital, they were trending his enzymes, and he had an episode of acute pulmonary edema and was taken to the cath lab urgently. His breathing stabilized with medications, and the cath showed this. So lesion in the distal left main, and the LAD is occluded or very slow flow in the LAD, and the proximal circ ramus has severe disease, and the RCA is occluded. So what next for this patient?
So maybe we'll start from Rhian this time and come backwards.
I think, getting a wire down that LED and imaging it and seeing if it's thrombus and considering, aspiration or moving on with small balloons to kind of just get your track and get the vessel opened, I think is going to get the patient out of that spiral quicker.
Do we know anything about LV function at this point?
The F is 20 to 25%.
Right. So I think you
and the outside hospital didn't have CT surgery in that hospital.
So I think that you need support here right away, and I agree. This looks like an acute or subacute LAD. occlusion, wire that, wire the circ, and dilate to try to get some flow and then image. But I think you need some kind of support here to do all of this. Because your LAD is already occluded, but your circ is greatly at risk.
Mechanical support, and then did you say CT surgery in-house or no?
No CT surgery.
No CT surgery, then I would wire I agree with her, I would wire the LAD quickly.
Yeah.
Yeah, I would agree with that.
So EF is low, no CT surgery. Patient's blood pressure, hemodynamics are fine?
Patient became stable after diuretics and nitroglycerin.
I'm sorry?
His hemodynamics, he was hemodynamically stable after his symptoms were resolved. Acute pulmonary edema got better.
If the hospital itself doesn't have CT, I mean, at my facility, I'll probably just go ahead, put mechanical support and go ahead. But if there's no CT surgery, it may be more prudent if the patient is stable to transfer the patient to a referring hospital.
On a balloon pump.
Yeah, I agree with all the comments here.
Yeah. So basically what they did was the cardiologist in that hospital placed a balloon pump and transferred the patient for possible surgery. So they didn't call the interventionalist, but they called the surgeon and got the patient for transferred for surgery. So the CTS saw the patient. I mean, he EF of 20-25%, so he consulted cardiology and heart failure. So by the time he came to the hospital, his lactate was 2.6, blood pressure was hanging low. He has all signs of cardiogenic shock. So at this point, the on-call cardiologist at our hospital talked to a bunch of us, and we agreed to proceed with a right heart cath and mechanical circulatory support with Impella, and then discuss at that point. His creatinine baseline was 1.5, now it is 2.8 or 2.5. So
and the surgeons turned him down? The surgeons said no?
Not yet. Not yet. She wanted the patient to be stable first. So these are the numbers of right heart cath, low cardiac output, and the LVD is close to 30. So balloon pump was switched to Impella. After switching to Impella, the levo requirements got better, and he was awake throughout this whole thing. He was still not intubated, and he was able to make all his decisions at this point. So we said, I know the creatinine is 2.5. Why don't you take one picture of the left main to see how it looks, the LAD.
Yeah.
So he took a couple of pictures, probably 10 CTF contrast there, which showed now there is good TIMI3 flow in the LAD. Close to TIMI3 flow. What do we do now? So the one of the key things is a lot of operators have different comfort levels, right? I mean, there are some who will say, we'll fix them all. There are some who will say, oh no, I'm running away from here. So the good thing is we set up this combination of having a team that can discuss all these complex patients along with the surgeons, and that's what the cardiologist did. He picked up the phone and he said, well, let's have a discussion. So this is what we did. It's an ad hoc multidisciplinary discussion. There are a few of the so-called interventionalists got on the call, and the surgeon was on call as well. So a patient was awake, not intubated. The surgeon felt that he could be a good candidate for bypass. However, wanted to wait a few days before the patient had surgery. Diabetic, obese, 60, relatively young. So this is what the plan was, and the cardiologist was happy that he didn't have to intervene with someone whose creatinine is going up and a complex intervention. Next day, the patient had few episodes of VT and his condition worsened, cardiogenic shock worsened, now needed to be intubated and with respiratory failure. and he was doing very poorly, so the Impella CP was upgraded to Impella 5.5.
Can I ask one question about the antiplatelets? So the LAD had reopened, maybe the antiplatelets made a difference. Did you hold the Plavix in preparation for surgery? And is that why he re-occluded? Is that?
Yeah, no, he wasn't even on Plavix. He was only on heparin and aspirin. So at this point, when the Impella 5.5 was placed, surgeon was like, no, I'm not going to do anything for this patient. That's when we started him on Brilinta. We put him on Brilinta at that time. So before all this, patient also expressed that he didn't want to be on dialysis and long-term intubation. He didn't want anything for a long-term support. So what do we do at this point?
All right, so essentially the patient is doing worse. The surgeons are not excited to go in, right, especially with the deterioration. So it's do PCI or nothing. Maybe you're called in for jury duty, but someone has to do something, I guess, if you're going to get in. Otherwise, looks like, unless any other thoughts. All right, since this is on the left main PCI case, I suspect you went ahead.
So what happened, that's what we did. All intervention was put on hold, and the heart failure team started managing the patient aggressively. So we went on jury duty and then came back after 3 days, and his renal function improved. He was extubated. He had Impella 5.5 in his right axilla, and he was able to make his own decision, and he wanted to proceed with PCI. So now, this is the angiogram with the distal left main, LAD, ramus, and circ, heavily diseased. What would we do for the technique? So he has the Impella in his right axilla, and obviously the right femoral artery, right radial artery is not an option. And then, and his creatinine got better, 2.2. So basically what we did was we took a EBU 375 guide, wired the OM prior to even taking any images. We used the dynamic coronary roadmap on our X-ray system, so we didn't have to use any more contrast until after intervention. And we were happy that the patient had the Impella in place. He was awake, still not intubated, so he had a lot of back pain because of his body habitus. We used Davies liberally for lesion prep, and this is the picture. The first picture we took was with the wiring and the OM. So from the intervention standpoint, what we did was we also cutting balloon atherectomy, stented the ramus using balloon-assisted T-stent technique into the circumflex. It's not really a ramus, it's probably a OM1. And then stented the left circumflex and LAD with DK crush technique with LAD as the main branch. Kissing balloon with 4 millimeter NC in both LAD and circ. Part was done with a 5.5 millimeter NC balloon. Total contrast was less than 20 cc. Multiple runs of 5 was used. So these are the final angiogram.
Yeah, perfect. I mean, this is an excellent result. So just throwing it to the panel, so anything you would have done different here? Obviously, it's very low contrast, a lot of intravascular imaging, two-stent technique. I mean, and Rhian, any other thoughts?
That was an excellent result to that case. And I think these are excellent cases to showcase that you can get away with very minimal contrast, but learning to do minimal contrast PCI, this case would be very challenging, but do that in your standard PCI cases and get comfortable with just IVUS running, marking it. These are all great things to learn, particularly as an early career.
Yeah, great result, and you can't argue with that result. So whereas I would tend to, in complex bifurcation, go with DK crush, this is certainly simple, and you're minimizing contrast. The only other thing I would say is that when the surgeon says, I want to wait a few days, this patient was not going to do better. He was not going to improve with that anatomy, and I would have just gone ahead and done it that very day and would have avoided a lot of the trouble that you had subsequently, but wonderful result.
It's a beautiful case and beautifully done. I'm just going to agree with Vlad here. The only question to me is the timing. You sort of knew the way it was going to go, whether you would have done this on day 0, day 1, would be the only thing to consider, but I can't argue with an amazing outcome.
Yeah.
I agree.
Yeah, I think I really like the use of IVUS and the use of 8 French guides. I think are really important for left mains. I think it was handled very well and very nice result.
Really, one innovative aspect of your stenting strategy, which was done in 20 cc's of contrast, is you also got the ramus. The T-stenting of the ramus and then a DK crush of the left main was really nice.
Srini, just a question here. How did the patient do ultimately?
He did very well after this. His creatinine went down further, continued to go down, and he wasn't intubated. Impella came out, and he's still in the hospital. Actually, this was less than a week ago.
It's sometimes we don't have any other choice, but I would say that, you can do a PCI in a shock patient, but when you end up doing a chip in a shock patient, they really get a big hit. And I think I like the fact that I think you need to be minimalist in these cases when they're in shock. It's very different than when they're not in shock, but when they're in shock, the shock trial was not under Impella, but sort of confirmed the fact that you should probably limit to what you think is the biggest bang for the buck and not go for everything. But we're always like, tortured and doing something, but when they're in shock, I think what is reasonable also is to make a trial of self-selection and putting an Impella 5.5 and waiting before they improve their kidney and everything, and then bring them in the cath lab has been my approach. I usually don't go early in these cases because I've seen too many expiring afterward, and despite having beautiful open coronaries and everything, but they just don't make it, and if they're in shock. So I think it's one thing that a lot of people have sort of shy away is being early, very aggressive intervention in these shock patients that have like horrible coronary anatomies, because surgeons have learned not to do these cases because they know they die. So the reason why we're not better than them, we're just gonna revascularize it. I think it's reasonable to wait and make them be self-select the ones that are most likely to survive over a few days, and it's probably what you did here. Yes. with the Impellas. The guy was not dead; he was surviving. He was not thriving, but then you say, okay, I think I can do something.
That's absolutely correct. Just waiting on until he gets better.
So the only thing is he was actually deteriorating. He wasn't getting better with time. He deteriorated and he went into worse shock. That's why.
I think one opportunity could have been when the surgeon said they wanted to operate and we held off. I think that could have been an opportunity where, I don't think that would be possible in someone of 20%. We should have just done intervention at that point on support because he was still not intubated and doing well. This was only after the decision was made about surgery that he started deteriorating.
Wonderful. Thanks again, Srini. Thank you so much. And then I will go to the last case because of time. So Dr. John Lopez is going to talk about, again, the last but not least case for the day.
Question from our audience.
His LAD recannulated. When they turned him down for surgery and the LAD was out, waiting around was not good. But they got lucky that the LAD refilled.
Yeah, no, great point. Thank you.
All right, well, thank you to all the hardy souls who decided to wait for the last case of the day. So in 7 minutes, I'm going to teach you everything you need to know about anomalous coronary arteries. But before I do that, I wanted to thank Manos and the organizers. Being both a panelist and a speaker here today, I would say that I have gained much more from being here these last few days than I've given, and I think most people on the panel would say that. It's just a tremendous format. So, this is my case. This is a 44-year-old male. He has a history of asthma, diverticulitis. He had a sigmoid resection about 2 weeks ago. He came back into our ER about 2 weeks post-operatively, presenting with shortness of breath. That time, his creatinine had gone up to 3.8 from 0.6 at his baseline. His white count was 19, had a hemoglobin of 17, was C. diff positive, and was admitted to a surgery service for antibiotics and IV fluid. Later that morning, he developed shortness of breath, chest pain, and had this EKG, and was brought to the cath lab. So this was not my case. This was about a month ago. Was one of my very junior partners in his, I think, first or second year out of fellowship. And so he was tasked with this case. And you can see in the REO view here, he's got a left coronary artery system arising from what looks like really the right coronary artery. So I'm going to stop here and hand it over to you, Manos.
Right, and I'm going to hand it over to Amit.
That was a good trick, Manos. You know, I can't, the flow is so brisk, John, that the RCA, I can't see very well.
Yeah.
It seems to me...
Let me see if I can play that again, because the RCA is a problem, and it's a big problem, and I'm hoping that I can go back and show this again, and I might need some help doing that. Clearly, I need some help doing that.
That's okay.
I need a lot of help doing that.
That the ostium of the RCA as well as the mid to distal RCA have quite a bit of thrombus.
Can you play this slide for me? So the mid-right coronary is very ectatic and has a huge thrombus burden. And if you look past the PDA, the actual distal vessel is thrombotically occluded as well. So there's a lot more to this. Can you play the image on the right here?
All right, so essentially you know what the culprit is, right? And obviously there's all these other branches who are at risk, but you know what the culprit is. So, I don't know, Rhian, is that something you just go, penumbra, stand, done?
I mean, that makes it sound easy, yes. I know what's his EF at this point?
He, for all extents at the time, we would say it was normal, right? We knew nothing about him. He's a 45-year-old guy, had no prior cardiac history, so
okay. And
we're flying blind here, right?
Yeah.
And this is, you know, obviously symptoms of his MI started within that period of arriving at 7 a.m. and noon, right? So we know we're within a window where we expect he has normal function.
Yeah, and I think in this situation then, I mean, doing an LV gram quickly can give you that idea too, if possible, but yeah, penumbra is a great answer to it. When there is aneurysmal and ectatic as this, sometimes just get the blood restored, see kind of what your vessel size is by IVUS. This may be a time where maybe doing DCB as opposed to getting a stent that's malopposed, kind of like what we've seen in some of the earlier challenging cases today, would be an option.
Wonderful. Would anyone call the surgeons for this?
It looks like a no.
All right. And then,
Jackie,
how concerned are you for compromising the other branches?
That's the big question. One of the big issues, right?
Yeah, no, I was actually going to say that I think that the concern always with any aspiration device is the potential for dislodging thrombus more proximally, and you're now basically having all of the coronaries supplied by that one vessel. So I would have concern about an aspiration device, but I mean, I understand you probably don't have a choice, but I have some concerns.
Manos, that's a really good point. With penumbra, is the risk of embolizing the clot elsewhere a little bit lower in your opinion?
Well, I think the risk is with any thrombectomy device, there's always a risk, right? I mean, and if you're concerned for the other vessels, now you could potentially deep seat a guide, maybe get a multi-way down there, or use a guide extension and try to minimize it that way. But I mean, I completely agree with Jacqueline. I mean, this is one of the main risks of the case.
How about, in this condition, first of all, EKG was very impressive. It was showing the very proximal right coronary artery affecting the right ventricle. V1 was more elevated than V2 and inferior wall changes. In this condition, I know patient has very recent post-op, small dose of thrombolytic, where it helped to prevent the regurgitation of the blood clot, which can be havoc in this patient. I had a patient in a circumflex big clot. I once gave her a 5-6 milligram of TPA, and then I was able to see the LAD origin, which was absolutely flushly occluded, and that patient did very well. In this condition, I think if there's no contraindication, small dose of TPA will be helpful.
Yeah. Excellent point. So that's intracoronary thrombolytic, not very commonly used, but definitely an option. Yes, Vlad.
That's what I was going to say. Actually, I haven't done it in years, maybe decades, but this might be a role. It's a very, very high-risk vessel with lots of thrombus. Penumbra is risky, and you give a little bit of lytic, and then once that's worn off, maybe leave them on a 2B3 inhibitor for 2-3 days, and then have a relook, and it's going to look very different, I think. And you already have flow.
So I am a little bit comfortable with that strategy as well, and it's not what was done here, but it's what I would have considered. But I just want you to recall as well that he's less than 2 weeks out from major abdominal surgery as well, right? And a small dose of intracoronary thrombolytics might not be a big risk, but
we still don't know what the cause of this is, right? I mean, there's no atherose, massive volume of thrombus. I just want to go back to Manos's point. I mean, if we get flow down with a balloon, I think it's all you might need to get a balloon, then you maybe start thinking about what the heck's going on and maybe engage surgery. I think flow, I wouldn't suck balloon flow and figure out the diagnosis.
Yeah, I think that you're kind of stealing my punchline, doctor, but that's all good. It's all good. So we'll go on, and I'll show you what was done here. So much as Mano suggested as well, here we go. JR4 guide, a guide extender, wired pretty easily into the occluded posterior lateral branch. There was initial ballooning with a very small balloon. Thrombectomy was performed with some improvement. You can see just a huge, massive thrombus burden. Can you run the image on the right again for me? Huge thrombus burden in the mid-vessel, the kind of which, there's no hope to aspirate this, right? And with the reestablishment of at least TIMI2 flow, TIMI3 flow in the PDA, TIMI2 flow in the... Should we show the right image one more time?
So, and then there is this option, John, I don't know if people have done it, but there is this stroke stents that you put it in the cerebral artery and then they can get big clots out. Yeah. I don't know if you have access to those, if anyone has used it,
we have a very good neurointerventional team, and I think if this were a daytime, that might have been an option, but I think on a weekend it probably was not an option, but yes. But I think, one of the points here, and there's a lot of teaching points here, is going to be we have to consider this in the context of what the risk is of his anomalous coronary disease as well, right? And what the ultimate treatment for that is, right? So I'll just review here what was done here. So angioplasty of the RCA with thrombectomy, JR4 guide, simple wire, small balloon, guide extension support, thrombectomy, there's some distal embolization, a slightly bigger balloon, some improvement in flow, and the operator stopped, which I completely support that decision. There was no effort here to do any additional definitive treatment of this. He was placed on integralin, Plavix, Eliquis on discharge. His EF, at this point, I'll come back to the end of this, but I think some of the clinical challenges have to do with the acute MI, but I think we also have to stop and think about how we categorize and think about anomalous coronary arteries, right? And those questions have to be, how should we categorize these patients? What are the features that are high risk? What's the best treatment option for the patient ultimately? And when is PCI appropriate, right? We would all agree on a panel that in this situation of an ST elevation myocardial infarction, getting this vessel open, establishing some flow was the first step, maybe not definitive therapy, but the first step. But this is not the typical case of anomalous coronary arteries that we're going to see, right? So I won't belabor this point, but certainly we have to think about what is the course and how do we categorize the anomalous coronary, being specifically concerned about this interarterial or malignant course between the aorta and the PA, less concerned about some of the other anomalies, right? We want to also think about what are the other high-risk features, the slit-like ostium, the acute angle takeoff, the proximal narrowing of the vessel, various anatomic features which we want to sort out as well when we see a patient of this sort. And then think about the diagnosis, right? One of the, I think, teaching points here is that, yes, in an acute coronary syndrome, we need to do something, but most of the time, that's not what we're going to encounter. And I would say that what we want to do really is counsel against proceeding to treating patients with anomalous coronary arteries who are not in an ACS situation until we understand the anatomy. Maybe that's with a CT, maybe that's with an MRI, or whatever modality you and your institution are comfortable with. It's important to truly understand the course of the vessel and understand the risks involved, right? What is the ultimate best treatment option for these high-risk patients? Once we understand the course, there are courses where the prognosis is quite excellent. But in fact, if we look at the recommendations, recognizing that the AHA, ACC guidelines are based on a very low volume of data to support these recommendations, this is a patient one would say should probably have surgical revascularization at some point. An anomalous left coronary artery, regardless of ischemia or symptoms, carries with it a class 1, possibly a class 2A recommendation for surgery. So I'm going to end with this and let the panel take over here. But on follow-up, he had no further symptoms. He was discharged with this preliminary treatments, EF of 45%. To answer your question, he actually had a history of recent and prolonged cocaine use, which may in part contribute to the synctatic coronary vessel and be a player, so to speak, in his presentation. And with a plan, once these issues are resolved for a CT, this has only happened within the last month or so, and then further evaluate him for the possibility of surgery. So I'll stop there and let you guys finish up.
Perfect. Thank you so much. Thanks, John. That was an excellent case. Farsad, you have a question?
About a year ago, like a 52-year-old gentleman, construction worker, inferior MI, wasn't anomalous coronary, but it was a huge right, and it was full of clot. So I wired it, penumbra, balloon. I got like TIMI2 flow, but if I were about to stent, it was like extending the whole thing. I wasn't actually happy to put a device there, and so I stopped. I said, I'm gonna put Interglin overnight, see how he does, bring him back later. His chest pain resolved, STs came down. I did echo, RV was actually enlarged and not moving very well. So I was really worried about him, but symptomatically he was getting better. So I put him on aspirin, Plavix, and Eliquis. And after about 2 months, I sent him home. After about 2 months, came back to the office for the second visit, had some indigestion. I thought maybe this is coming back, this is the time to really look, see what's going on. I did echo, his RV absolutely normalized. I look at the right corner, I couldn't believe it. Absolutely normal. We did hypercoagulable workup, I couldn't find anything. So I had no explanation what happened, but I think the best thing was not to put the stent there and just accept the...
For more than one reason, probably, right? For more than one reason, absolutely.
Wonderful. Any thoughts from the panel? Oh, there's one more question back there from Dr. Xenogiannis. But I think the lesson here is that sometimes you don't have to get a perfect result for this, and sometimes getting some flow, and it's like a star. Getting some flow and giving it time and some of the calculation can work. Yes, Yosef.
Yeah, actually, great case. Thank you so much. I totally agree that you shouldn't put the stent there during the index procedure. However, what could have been done differently is to repeat the coronary angiography after like 3-4 days, and then try to IVUS or use an OCT, better OCT, to see what was the underlying pathophysiologic mechanism there. And if it's like a huge rupture, then you might have to stent it, or otherwise you can leave it as it is.
But if you believe, right, in this case, that this is a young gentleman who's destined for bypass surgery anyway, why bother, right?
Yeah,
that's the alternative argument, right?
That's perfect. Yeah, if it was like in your mind that he might need surgery, then that was the right thing. No, don't do anything else. Thank you.
Okay, and last question, Dr. Elrace, up in the front. Can we give right? Just give it 1 second. Let me get you the microphone to you.
Could you use laser thrombectomy? Laser, not thrombosuction.
I suppose you could have done a lot of things, you know, in this situation, but I think, you know, I think there's two concerns here, right? One is we don't know why this happened, right? And the goal here is to establish some flow to get him out of the acute ischemic episode. And then the bigger question here is what's the right ultimate treatment for this guy, right? Does he deserve any definitive treatment on that index day? And I think the answer to that is probably no, right?
Okay, and I guess Dr. Chavez has a question. Right here in the front.
Dual versus triple therapy. I noticed that you had placed your patient on Eliquis as well. As you
Yeah, I don't know that there's an answer to that. I think it's a low data zone, so to speak, but certainly happy to hear other expert opinions on what the right regimen for this guy is, but I do think some oral anticoagulation is indicated given the burden of thrombus and the ictation. So.
All right, well again, thank you so much. John, that was a great case. Thanks everyone for lots of learning today. Quick reminder that